Hello and welcome. Today, we are diving into a tool that I think can honestly change the game in how you manage periodontal health. We're talking about the Periodontal Risk Assessment model. This is all about getting proactive, about personalizing care instead of just reacting to problems. So let's jump right in. Okay, picture this. Your patient has just finished up a successful course of periodontal therapy. Everything's looking great, their gums are stable, the inflammation is gone. That is a massive win, right? But now what? The real question is, how do you make sure all that hard work sticks and the disease doesn't just come roaring back?
And that question brings us straight to our first big topic, the post-treatment challenge. You know, this phase is absolutely critical. It's where the long-term success of your treatment is really won or lost.
So the answer to that challenge is a solid maintenance plan, what we call Supportive Periodontal Therapy or SPT. The whole point is to keep the disease from coming back. But, and this is a big but, SPT is not a one-size-fits-all deal. A patient who's low risk needs a totally different game plan than someone who's high risk. Here's a quick look at our game plan for today. We'll kick things off with that post-treatment challenge we just talked about. Then, we'll introduce the Periodontal Risk Assessment, the PRA, as our go-to predictive tool. We're going to break down the 6 key risk factors it uses, show you how to calculate a patient's overall risk, and then, the best part, how to turn that risk into a custom recall schedule. And to wrap it all up, we'll walk through a real-world case study. All right, let's get to the good stuff, the solution. We're talking about the PRA model. This is the evidence-based framework that lets us stop guessing and start personalizing supportive periodontal therapy for every single patient. So what is the Periodontal Risk Assessment really? Well, it's a systematic way to figure out a patient's risk of their disease coming back. And why does that matter? Because it lets us dial in the perfect frequency for their maintenance visits. This way, we're not undertreating the high-risk folks or overtreating the ones who are perfectly stable. It's about finding that sweet spot. You know, a great way to think about it is like you're creating a unique periodontal fingerprint for each patient. It gives you this fantastic visual, like a risk radar, that pulls together all the important variables into one simple, easy-to-read snapshot. So what actually makes up this fingerprint? Good question. It's built on 6 key risk factors that we need to look at for every single patient in maintenance. Let's dig into what they are. These are the 6 data points that make up our risk radar. You've got bleeding on probing, any leftover deep pockets, tooth loss, the bone loss to age ratio, systemic factors, and of course environmental stuff like smoking. Let's break each one down. First up, bleeding on probing. This is our #1 sign of active inflammation. If a patient has less than 10% bleeding, they're sitting comfortably in the low-risk category. The real magic number here is 25%. Once you go above that, the research is clear. They are at a much, much higher risk for future breakdown. Next, we have residual pockets that are 5 millimeters or deeper. You got to think of these as little reservoirs of bacteria just waiting to cause trouble. If a patient has 4 or fewer of these, that's low risk. But if they're walking around with 8 or more, well, that puts them squarely in the high-risk category. Our third factor is tooth loss. It's actually pretty simple. A patient's history of losing teeth from perio is a really powerful predictor of what's going to happen in the future. Losing 4 or fewer teeth is a low risk, but losing more than 8, that's a major red flag for high risk. This brings us to what might just be the most clever factor of them all, the ratio of bone loss to the patient's age. This quote really nails it. It's not just about how much bone they've lost, but how fast they lost it for how old they are. This gives us an incredible picture of how aggressive the disease has been. And the calculation is surprisingly simple. You just take the percentage of bone loss at the worst spot in their mouth and divide it by their age. If that number is greater than 1, it's pointing to a very aggressive disease history. That automatically makes them highly susceptible to future problems and lands them in the high-risk category. And finally, we've got the modifying factors. Things like systemic conditions, diabetes is a big one, can totally change a patient's immune response. Then you have environmental factors like smoking, which has a proven dose-dependent negative effect on healing and long-term stability. These are the wild cards. Okay, so we've got our 6 individual factors. We've got all the pieces of the puzzle. Now let's look at how we put them all together to create that overall periodontal fingerprint and get a final risk level. The process is really just a straightforward 3-step recipe. First, you assess the patient on all 6 factors. Second, you just count up how many of those land in the moderate or high-risk zones.
And finally, you apply a very simple set of rules to get your final risk classification. Easy as that.
And here are those rules. A patient is considered low risk if they have at most one moderate factor and 0 high-risk factors. They're moderate risk if they have at least 2 moderate factors, but no more than 1 high-risk factor. Now, here is the most important one to remember. A patient is automatically considered high risk if they have 2 or more factors in that high-risk category. That's the big one.
All right, now for the payoff. We've done the work, we've calculated the risk. Let's see how this translates directly into a personalized, evidence-based maintenance schedule for our patient. And here it is. This slide shows that beautiful, direct link between our assessment and what we actually do. The PRA model gives us these clear, evidence-based recommendations. Low-risk patients can go on a 12-month recall. Moderate-risk patients should be seen every 6 months. And our high-risk patients, they need to be on a tight 3-month interval to stay stable.
Let's pull this all together and make it real. We're going to run through a quick case study to see this model in action. So meet our patient. She's a 27-year-old female, and she's a heavy smoker. Let's run her numbers. Her bleeding on probing is 36%. That's a check in the high-risk box. She has 10 pockets over 5 millimeters. Check, another high-risk factor. Her tooth loss is low, only 2, so that's good. But her bone loss to age ratio is 1.4. Wow, that's our 3rd factor in the high-risk category. So what's the verdict? With 3 factors, her bleeding, her deep pockets, and that bone loss ratio all screaming high risk, the conclusion is crystal clear. Remember our rule? 2 or more high-risk factors puts her in the overall high-risk patient category, and that means she absolutely needs a 3-month recall to stay stable. You see, the PRA model gives us this clear, logical framework for managing our patients for the long haul. It moves us beyond guesswork and into predictable, truly personalized care. So, I'll leave you with this question. Think about your patients. How are you going to use this periodontal fingerprint to change the way you approach their care? Maybe even starting tomorrow.